Good morning. How are you?
I'm very, very happy to see you after a long time.
Yeah, after a long time.
Yeah,
Hope everything is and everyone is fine there.
yeah, perfect. Things are going on quite smoothly without any challenges. And we
Okay.
have changed our approaches. We have started a couple of field sites. One is in urban slum. Earlier, we were doing
Hmm.
most of the activity in the rural area. Now we have witnessed, I mean, there are a lot of COVID cases and deaths we have seen more in urban slums than in rural area. And there has been a reasonably good support system in the rural compared to urban slums, I would say.
Hmm.
There is a tendency to believe that urban is reasonably better. They can access the healthcare services. But in our
It's
observation,
half truth. Hmm.
yeah, but we have witnessed close to 40 to 50 people with a population of 15,000 have died due to COVID in the month of April and May. And we have documented that. Second thing, almost 14 people committed suicide in 1 year period during this period from that particular slum. And the
Wow.
reasons are many, but the thing is that they are not having job, and someone is working as a driver. Suddenly, they could not get a job, or they are taken out. I mean, there was a family fight, and so ended up committing, suicide. This sort of a stories, we have documented, and we are shortly going to publish in a peer-reviewed journal article as well. So, in the entire process or a journey, we learned many things. Earlier, we were using digital devices, but now we slightly improvised using the Bluetooth-enabled devices to automatically capture the data of blood pressure, blood sugar, so that the data entry, manipulation, late entry, that information, errors in the data entry, all this we eliminate. In
Yes,
any
sir.
case, let me formally welcome you, sir.
Thank you
And
very much.
it's a very wonderful, very nice, very happy to have you over here. It's such a beautiful day that I'm honored to talk to you and listen to your community health work in slums and some of rural areas that you have been doing it. So I'm delighted again to welcome. And if you permit, I will record this video as well.
So Aurangabad was the fastest growing city of Asia in the 80s because of the some automobile cluster formation here and industries were coming here,
Mhm.
and lot of people in nearby 16 17 districts were migrating to Aurangabad.
Okay.
That was a typical phenomenon, and the migration was not only because of the economic reason, mere economic reasons,
Mhm.
but especially there was a tinge of social injustice to them, to their migration. This
Mhm.
region is infamous for the untouchability practices.
Oh,
It was a part of the Hyderabad dynasty, Nizam dynasty.
okay. Okay.
So
I guess, do you have a presentation?
yes,
No,
so
my initial idea was to explore your sort of a passion to enter into. So basically, it's
right,
a very organic entry into this because of the medical
organic.
college and your inspiration from of key leaders who are there in the organization. Seems that they are the instrumental for you to take such a wonderful, very insightful. I mean, you are giving that interesting note of why you entered and how you entered, what is the
Hmm.
situation. So now let us listen systematically. I mean, whatever, I guess you have a presentation that might give us a
I
more
have.
clarity.
Yeah. So I am sharing now. Acha. Could you give me the screen sharing option?
Yes,
I hope it's visible.
yes, sir, it's visible. If you could expand the
Hmm.
slide show mode. Yeah, perfect. Now I can see.
So as I mentioned, this was a holistic approach towards development. Should a hospital only be a hospital, or could it change the community around it?
Okay.
That was the question, and that is the bottom line of this organization. The genesis is from the hospital, and later when we ventured out to various initiatives, especially the non-health initiatives, and coupled them with the health initiatives, the need was there to have two separate organizations to take care of both the things, both the streams, health as well. Health means secondary and tertiary healthcare,
And
and
then,
community health and community development initiatives.
mhm,
As the need arose, we formed an independent organization called Savitribai Phule Mahila Ekatma Samaj Mandal
mhm,
in 1994. The work started before the organization's registration through the
mhm.
hospital itself, and then we registered this separate entity. Both of them are legally independent but interdependent as it comes to operations.
Okay.
Right now, we have five verticals: health, then education, skill development, women empowerment, and natural resources management. We
Mhm,
cover around 300 villages in 5 districts. We started in Aurangabad city, then went to Aurangabad rural areas, then
mhm,
Jalna,
mhm,
Nandurbar, Bid, and Usmanabad.
mhm,
Right now, we cover around 62 slums in two cities, Aurangabad and Jalna,
mhm,
through various initiatives, not essentially not healthcare, but most of them are, we have our healthcare programs in there.
mhm.
And it probably touches more than 5 lakh lives every year positively. Around 33 projects are going on, 15 plus CSR associations, 150 staff is there, and 300 volunteers are there.
They're all
So
field staff.
field staff, then project directors, project coordinators, head of the departments,
Okay.
like that. There is a formal hierarchy nowadays, since we adopted the quality management system.
Mhm,
If you look at the bouquet of the projects, in healthcare, we have Sanjeevani Rural Health Program, for which we were there in Bengaluru
mhm,
last time. Is
mhm.
being supported by Wipro since last 11 years.
Okay.
And then the permanent health centers are there in slums. So Sanjeevani project is a rural health project with a special focus on maternal and child health. And it has different components, interesting components like maternal and child health, then adolescent health, then mental health component is there since last 5 6 years, and so on. Now currently we are working on NSDs and NCDs and so on. The urban slum health centers have a different model. They have daily OPDs, and more is being taken care for the primary health care, and has some structured preventive health programs and health education programs in a very well defined slum areas.
Okay.
There are three in Aurangabad. So in through these three slum healthcare centers, we cover around 35 slums of Aurangabad. Very densely populated, as I said, and had all sorts of issues there.
So
Now
my,
they are being,
no, sir, I'll be asking questions in between just to get a
yeah,
clarity.
definitely.
Under the health, there are too many names of the health activities.
Mm.
Why they are being named likewise? I'm just curious to know.
Because they are different projects.
Funded by different organizations, therefore you kept, or is it?
Yeah, funded by different organizations, and their geographical areas of operations are different, and their modes of working are also different.
Okay.
So there are two, three models. One is Sanjeevani model, where OPDs are less prominent, but then the more focus is on maternal and child health, then NCDs, mental health, and other components of community health.
Mhm.
And a horizontal model is there. We serve around 90 villages in Aurangabad district through that project very effectively. We have a network of Arogya banks and trained health workers in the district,
Mhm.
and they operate through that project. That is the Sanjeevani model. Then the next three are slum health centers located in a cluster of slums, serving a cluster of slum and located at the central place for all these slums. The doctor stays in the slum for 2 centers. Then the different model, another model is the mobile clinic serving the slums. You know, the mobile medical van which caters to slums. So there are three mobile clinics for three different clusters, one in Aurangabad, two in Jalna. So they
So,
serve.
so how is this SPESM, that is this health project, connecting the government healthcare system? Is it a complementing or supporting? Is there any linkages that you established?
Yeah, very weak linkages are there, but we are not competitors or not replacement to them. We are complementary to their work, especially when it comes to rural health. So we are complementary to them. In urban slum also, we take up some of their tasks, and we provide our infrastructure when they don't have any infrastructure to serve, like that.
So, what is the
Currently, the
key?
vaccine.
No, my question more specifically, what is the unique innovation that under this health project, in terms of what is innovation that you think, and what is that is a replicable and scalable model? And third
Yes,
dimension is that what is that sustainability part of it? Can you just
right,
elaborate on that?
right. So innovation wise, you may rate it quite lower because only a few innovations are there, like linking it to big hospitals and then have timely referrals, more focus on structured health, preventive health programs and health education. That is very important. uh, our focus is more towards the preventive health work, and you may find very innovatively designed preventive health programs, like the Samohik Dohal Jevan, like the 7 months ritual. We celebrate all the traditional celebrations related to the pregnant women and related to the children on a community level. Normally, you find the celebrations are going on in the families when a lady is pregnant. For the slum lady, nobody celebrates her pregnancy because of poverty and because of there is no nothing new for them.
Yeah.
Uh, we take up this as a cultural thing, and then took it as a innovation, and it got tremendous success. The
Okay.
attendance and regularity to attend the ANC clinic, the early registration of pregnancies, then availing the pregnancy services, everything improved after we started this
Using
celebration.
the cultural approach to bring the
Yes,
people
using
into the institutions,
right
engaging them
using.
for a better health and preventive healthcare services.
Yes,
Yes.
yes, definitely. Maternal health, especially.
Right.
And the same thing we replicate to child health issues also, to tackle the malnutrition. Then the traditional weaning celebration is there in families. So we have taken it to the community
So
level.
the innovation in the sense, like, there is absolutely very minimal or no services available, especially in urban slums. You started to improve those using the cultural notions. That is a kind of a real work that you
Participation,
have been, community
community
participation.
community participation in preventive health program is minimal
Yes,
everywhere.
yeah, that
Of
that
course, these slums are underserved when it comes to basic health services also. Yeah, before that, I would like to mention 2, 3 innovations. One is Shruti, the doorstep screening for ear diseases.
okay.
That is again an example. Innovation is there, but also the example of using technology for extension work in healthcare.
Mhm.
Then doorstep anemia screening we have started and is going on. The last two names in the project, Swanand and Rama, there is another project to be added. So they
Mhm.
are about dedicated project about anemia prevention and awareness programs.
Mhm.
Then the mental health component, the helplines and one-on-one screening, de-addiction centers. In a way, there was absolutely no system to tackle these issues. in the slums, and we added the things. Then screening NCDs was not there, and we have started doing this hypertension clinic, under 5 clinic. Our hypertension clinic has now completed around 15 years. 15 years ago we started, 15, 17 years ago we started hypertension clinics, and
Okay.
going door to door and recording blood pressure. And at that time the notion was, when we started there, people laughed at us. They said it's a disease for the white collared people, and why you are searching hypertension and diabetes patient in the slums.
But truth is
When
that
we
now we see more and more cases NCDs in poor people.
because
Urban, yeah.
stress is there, addictions are there, stress is there, everything is there. We also use the care mother kit. That is again innovation and technology, use of technology for maternal and child health. So these are
Okay.
some pointers which are related to these points. So the healthcare is around for 200 villages and 62 slums. These are the services we offer in our various health projects: OPD medicines with token cost, adolescent health counseling, effective telemedicine solutions, complete care of lifestyle diseases, specialty camps. Because we have a base hospital, we can afford to have specialty camps. Then anemia, pre-tubectomy, cataract, micro-ear surgeries to needy patients. Developing health leadership is what we call an innovation. At least in Maharashtra, nobody, very people have done this.
Sevanpur.
So Sevankur is the other thing. It's the next level of that. But developing health leadership through our health workers.
Okay.
We have a network of 200 odd trained urban and rural Arogya Mitras.
Okay.
And then door-to-door ANC care in remote tribal hamlets. So that is about the health programs. Of course, the results we map like this. So when we started, the malnutrition in 10, 12 villages was 51.2%, a whooping 52%. And gradually it has come down to 16.03, and we continue to map it in new villages also. And so the home delivery, we do not claim that the entire change from 51 to 16 has happened solely because of us.
1 second, you remember the Gadchiroli experiment of search organization? They systematically documented by giving a home care kit in terms of gentamicin, pre-filled injections, training, and how it has reduced, and it was published. My question to you is that, but is there any systematic documentation and publication has been done, or is it?
Systemic documentation is there. It is yet to be published anywhere. So documentation is there with us.
Okay, I'll be more than happy to have a look.
The mapping.
If you have a data set, if it is there.
Yeah, definitely. We actually desperately want to have a systemic publication of all these breakthroughs we have got in Sanjeevani project, especially.
But please let us know how we can collaboratively work on different areas.
It will be. I will connect Dr. Pratibha. She leads the department there. There is another very important project you will be very interested into, is changing the health behaviors. 5 types of health behaviors, and we have mapped it, and it is a very good success. Again, it was supported by Wipro. It started as a separate program, and it has involvement of the government teachers, government schools, government teachers, the health worker of the village. This picture shows that a rural lady, pregnant lady, is being counseled for reproductive health and ANC and PNC things.
Okay.
Coming to the second department, second vertical of SPMESM is education. We have a state level child education research project called Onkar Balwadi, which caters to 0 to 6 year kids with innovative. It is not actually innovative. It is the ancient concept of child education, the Panchakoshatmak Vikas, we call it as.
Okay.
So, Annamay Kosh, Manomay Kosh, Pranamay Kosh, like Anandamay Kosh, like that. So the curriculum based on the Panchakoshatmak Vikas. Then we have a learning center. Then Kishori Vikas Prakalpa is our another signature program. It deals with 10,000 adolescent girls, health, development, then relationship management, addressing their gender equality issues, and so on. Yes. This is the picture of Omkar Balwadi, and then the Vihanga Center, some initiatives of education thing. It's going on since last 27 years now. And the beautiful part is 50 odd ex-beneficiaries are volunteering on this program.
Oh,
the third one, which we were talking, is skill development. It started out of the need of holistic development, and because there were many livelihood issues for the slum dwellers. And basically the men are somewhat at the distant level of transformation, but the women are at the core. So empowering them with skills, new skill sets or short-term skill courses proved to be very successful thing. Currently, we have computer training centers for both boys and girls, and then beautician, food tech, and food processing and catering, and basic and advanced tailoring. All these courses are for women from slums, 18 to 35 years of age. Then electrician training mostly for the men's, computer courses again, and some geriatric care courses, etc. So in 6 to 8 trades, we train around 1,500 trainees. Most of the training programs has a placement rate of 70 to 80%, because skilling is one part, but entrepreneurship mind development is another part. So everybody who has got training from your institute will not go for, say, employment or self-employment. You need to have a entrepreneurship development, systemic entrepreneurship development programs going on for them. So you can see the graph here, and the last one in the corner is 1 year graph we have been doing with Jai Shiv Shakti. Again, the red columns are placements, and only if the trainee has started earning 5,000 rupees or more out of the training, we call it as placements. There, essentially, these are some success stories of the program. Then we have a fourth wing called Women Empowerment, and a program called Tejaswini. Again, it is very complementary to health, all the health programs, and it promotes education in the dropouts. It promotes family health in the slum couples or slum families in the slum. It also promotes mental health component is there. And another very interesting component is non-political leadership development. We work with around 5,000 women from different slums of Aurangabad. That is our Tejaswini program. The last vertical is natural resources management. So while we are talking about the slums, the villages were there and our health program was there. And it being a very vulnerable area to climate change, we were forced to do something in water management. So far, we have made 70 villages drought free. And with different initiatives, with agriculture extension programs, the productivity and yield has gone up. So in any program related to NRM, we straightway can claim 30% increase in their income from agriculture in 3 years. And it has been proved over and again in all the programs. So we are now into the next level of this, like FPOs and CBPOs formation and agri-marketing things. So these are some of the pictures of that program. Yes, you can see some examples here. This fellow has a papaya horticulture thing. He dared to plant it because we made some extra water available to him for irrigation in his village. before before the program, he used to earn in 75,000 rupees in his 1.5 acres. This year, he could get 4,50,000 rupees because
Excellent.
some additional water was available to them. The programs are not only engineering solutions, but hand-holding in agriculture management, integrated pest management, nutrient management, food safety,
Mhm.
and agri-marketing too. So appropriate agrotechnology, taking the appropriate agrotechnology to the farm
Mhm.
is next level to water programs. Yes,
Okay.
these are some glimpses of one village which was completely transformed to a surplus village, water surplus village, and they could earn 4.5 crore rupees from the ginger plantation, which was possible because of the water works we completed with support from PWC there.
Okay.
So effectively, Jan Jal Jungle Jungle Zameen Janwar.
Mhm.
So effective management of 5 J's is the key, and we got many awards for that also. So these are the essentials of what we do in 5 verticals. And here are some basics. One or two are very relevant. Like we consider ourselves only catalyst. People are the real change makers. So we don't play God to people. We are neither replacement nor parallel to government, but we are complementary to their work. And
Mhm.
we try to find only sustainable solutions. Everything is tangible, and that's why we have been implementing the very effectively implementing the quality management system, ISO certification in a social project.
Mhm.
Essentially, every project is goes through the logical framework analysis before we prepare it for sending to a funding agency,
Okay.
and so on. So these are some, and in technology and development sector, we have already spoken about the Shruti telemedicine solution for year and care mother. We have our own app for reporting, and we have designed our application. So
Mhm.
150 odd of our people, they real time report their stories, their events, and everything through that app, so that the precious resources are not wasted for the preparing a report actually.
Okay.
So these are some of the highlights of this, and thank you very much.
Sir, thank you. Thank you so much for such a wonderful, illustrative, beautiful presentation. Like, I was thinking like in 1 hour, we could definitely grasp what you are doing it. I can say that I could not get even 1% of, because it's so vast. It's not health and social determinants of health. And most importantly, you brought in the quality management into it,
Mhm.
to make sure that everything is as much as possible tangible, measurable, so that we can track it, which is a wonderful initiative, I would say.
Thank
Um,
you, sir.
I only thing
Dr.
is that
Pratibha wants to. Yeah.
yeah,
सर
Dr.
नमस्ते.
Pratibha.
namaste, madam.
एक
Wonderful, wonderful,
बात है कि
wonderful work.
आपने तो प्रेजेंटेशन तो देखा है, लेकिन I need some help from you.
We are
Definitely go
inviting
ahead
you.
with.
We are inviting him to Aurangabad. Soon he is
Yes,
coming.
yes, definitely.
Definitely, I would love to come, sir. Definitely, I would like to visit once, and then that gives a much more clarity. And let us continue to work now onwards, rather than waiting for my visit to Aurangabad and then start. I can
Yes,
only
sir.
say that this is this is doing an injustice if I'm just thinking that I grasp whatever you have done in 1 hour. It's a real injustice. I would say that it requires a many multiple similar sessions on one topic at a time. Thank you once again, sir,
Okay,
for
sir.
giving this
Thank
wonderful
you. Thank you very much
time
for your
and making the
patient listening,
presentation.
your insights.
Thank
Thank
you,
you.
sir. Thank you so much.
We'll keep in touch.